So obviously with all of this complex function, we would call it, I think the room for error is pretty high. Found a couple stats on here that I honestly found surprising, even though I treat jaw pain, headaches, neck pain, and all that. 5 to 10% of the population will have jaw pain. That was a 2018 study. I tried to find some data post-COVID because I feel like COVID literally poured gasoline on this. We'll get into that a little bit. But 5 to 10% of the population has jaw pain. Women make up about two times the percentage of men that have this. And 48% of people that have jaw pain continue to have jaw pain 6 months down the line. So I think that the treatment options aren't there. The current, way people are treating this is not good if 50% of people still are having the pain 6 months later. And then I found an interesting study that goes along with the COVID theory a little bit. It was 2 dental studies. There's a 3-fold increase in nighttime grinding during the COVID lockdown. And it went from saying 10% of the population, I believe it was looking at males, have nighttime grinding the teeth, went up to 30% during COVID. So I find all of this interesting. I literally got into practice in 2020, the middle of COVID. And I remember the amount of people that had jaw pain, had headaches, had ringing in the ears, had vertigo, that were like, I'd never had this before, was striking to me. It was like such an interesting time to get into practice, whereas this something that's never happened in the world. So I'm curious all your thoughts on that. But, who has this problem? Who are you seeing that has this the most?
Yeah, primarily it is going to be younger individuals. So we don't tend to see a lot of people who are 50 years old and up who have these jaw issues. Sometimes they can come on, especially after long dental procedures and things like that, something that would be like a trauma to the jaw. But most of the non-traumatic jaw pain is going to be in younger populations. So generally somewhere between the ages of 22, 25, and kind of peaking at around that 35 to 40-year-old mark. So it's primarily a issue that affects younger adults, and unfortunately, that's during your prime working years, right? And it does tend to have a prevalence towards women, right? Part of that is that women's jawline and jaw structure tends to be a little bit more narrow than men's. Men tend to have a little bit of a wider and thicker kind of jaw structure. There's things that can go into that, like narrowing of the maxillary arch, so the arch on the top of your mouth. If that becomes narrow or the chin becomes kind of recessed, we can start to get some different airway issues that lead into this dysfunction. But it does seem to primarily affect women, and it tends to be women between the ages of 20 to 25 to 35, 40 is the primary demographic.
And what are most of these patients doing for this? Are they ignoring it? Are they popping ibuprofen? What are they doing?
So unfortunately, the treatment options are not very high. So usually when you have jaw pain, the first person that you approach about it is going to be your dentist, right? So your dentist is going to do their job. They're going to check and make sure that your bite is appropriate. If you have a good dentist and your bite seems appropriate, but they still have pain, they may prescribe you steroids. They may prescribe you muscle relaxants. They may prescribe you general pain relievers. But if you have a good dentist, they're probably going to get you into a night guard or some type of oral appliance. And night guards actually help a tremendous amount. I know we're going to talk, I think, a little bit about night guards later, or we could get into it now, but
it's fine. Those
are kind of your treatment options, right? Past that, when those things don't work, so these what you would consider the traditional conservative measures, most clinicians, whether it's dentists or medical doctors, are not really recommending physical therapy. Sometimes they do, but a lot of physical therapists are not super well trained for the jaw. Yeah. So there's not people to refer to.
Right.
They're not, certainly no one's recommending chiropractic. I'm trying to do my best to change that and make us kind of a frontline option for dentists. I work with a couple of dentists now who are sending me patients, and we're starting to develop a good relationship where they see the results. But a lot of times you're just left with, okay, if the medications didn't work, your night guard didn't work, just deal with it.
Are we talking a custom night guard or something off Amazon?
So there's 2 different kinds. We can get into this right now. So there's just your general kind of over-the-counter night guards. The purpose of those night guards is to protect the surface of your teeth, okay? So when you go and get a night guard from Walgreens or you order one off Amazon, they're usually thin, rubbery. Sometimes they're thicker and rubbery. The primary purpose of those is so that when you're clenching or when you're grinding at night, you don't crack your tooth. So you don't crack your crowns, you don't crack a tooth that's weakened because of a cavity, yep. You don't, disrupt a filling. What they're not designed to do is actually help with the jaw issue. And oftentimes those generic mouth guards do more harm than good, because although you are protecting your teeth, if the teeth were not the source of your pain, the jaw joint or musculature is the source of your pain, Giving you something to bite down on allows you to clench harder or grind more in your sleep. And so oftentimes patients use these generic night guards and they get a little bit less pain immediately, so in the short term, and that's because they're getting less sensitivity from the nerves inside the teeth.
Okay.
But as that pain starts to go away, they tend to develop more pain over time that's actually related to the joint and to the musculature of the jaw. Custom night guards, there's a few different kinds, right? There are still dental custom night guards, and this is what you want to talk about with your dentist if you've got jaw pain. You want to make sure that when they do your night guard, they give you a kind that gives you a little lip that separates the front teeth. You don't want one that just goes all the way across, protects all the surface, because we're back in the same territory.
Okay.
So this little gap basically makes your top front teeth and your bottom front teeth hit before your back teeth can touch. That little bit of separation, your brain kind of realizes, hey, we don't have an even surface and it's not safe to clench. So it kind of short circuits the reflex for clenching and grinding at night. So that slight gap on the front teeth is going to help you neurologically stop the clenching and grinding cycle overnight. And for a lot of people, it's that clenching and grinding that's driving the pain. So most TMD, so temporomandibular disorders, are actually myogenous, so coming from the muscles in nature. You may be familiar with metaboception or metaboreception. It's something that we didn't really learn in school, but it's another type of sensory reception. So we have like nociception is to feel pain,
Right.
thermoreception is to feel temperature, baroreception is to sense pressure, right? These are all different types of sensors that our body has. But we also have metaboreceptors, and that's receptors in your body that pick up on the metabolites or the metabolic products, byproducts of muscular activity. So, one of the things that people always hear about is lactic acid, but there's a variety of metabolic byproducts. But the harder a muscle works, the more energy it burns, and the more byproducts from that burning of energy are left in your bloodstream, especially locally. So metaboreceptors trigger your brain to perceive pain. So it's one of the reasons if I sit here and had you clench your fist for 30 minutes, right? You're going to be in quite a significant amount of pain from sitting there and holding that. Or if I had you, hold a bucket out like this and I come back in an hour, right? You're going to be really hurting. It's from the metaboreception. So this muscle is overactive. So that's one of the primary drivers of pain in many TMJ disorders. You're clenching so long and so hard, building up metabolic byproducts, and your brain is perceiving this as pain. So finding a way to get you to stop clenching and grinding at night helps a lot. The other thing that helps a lot is a lot of patients are clenching and grinding during the day, and that's a stress response. Now, you can tackle the stress. That's sometimes easier said than done, right? Just don't be stressed. So just change everything about your life that stresses you.
Don't do it.
But you can teach them strategies. So the natural resting position of your jaw, your tongue should be lightly pressed to the roof of your mouth, and your teeth should not be touching when your mouth is closed. So your lips are closed, your teeth are slightly separated, and your tongue's lightly resting on the roof of your mouth. That's what we call the position of rest. And a lot of TMJ patients either have the tongue flat on the bottom, the tongue's pushing forward, pressing on the teeth are slightly touching or strongly touching, clenching during the day. And so teaching them to kind of check in with themselves, sometimes you put a hair tie or a rubber band on your wrist and you'll snap it, when you notice yourself clenching. Or you can set an alarm on your phone for every 10 minutes and it goes off. You go, oh, am I clenching? You start to ingrain the habit of keeping this position of rest, and you'll notice when the pain is from that increased muscle activity, this knocks out 80% of it, sometimes 100% for some people. Is just teaching them to find that position of rest where they're not clenching all day long.